Thank you very much, Dr. Ganguly, for all those kind words. At the outset, I'm thankful to BDCon organizing committee, in particular to Dr. Amitabh Vishwas, a very old, close friend. Early days, 20 years ago, he was working in Delhi and we shared many times the dais. So thanks for remembering me. And you'll appreciate that my task has been done more difficult by a wonderful oration by Dr. J.J. Mukherjee. And towards the end of the day, I'll still try to do some justice to the topic, what has been assigned to me, what is metabolically associated fatty liver disease or MAFLD, and how to check this growing pandemic. Objective of my session will be to discuss the relationship of MAFLD with metabolic syndrome, type 2 diabetes, and underlying pathophysiological mechanisms. We know metabolically associated fatty liver disease, or what popularly has been known as Nephil. It is one of the commonest chronic liver impairment in absence of significant alcohol intake or secondary causes. That means you practically rule out alcohol as a cause of MAFLD or Nephil. Obesity and insulin resistance primarily predispose this condition. It is closely associated with metabolic syndrome and other abnormalities. It is progressive, has potential cause end-stage liver disease, and could lead on to hepatocarcinogenesis. And cardiometabolic diseases may also dictate the outcome. So let's see what is Nephil. It's a chronic liver condition which is characterized by hepatic fat accumulation in the absence of ethanol abuse, I told you, usually associated with insulin resistance, hypoglycemia, and CVD. NFL is when you have presence of fatty liver without hepatocellular injury, that means without ballooning. NASH is when you talk about presence of hepatic steatosis and inflammation with hepatocellular injury, which could be still with or without fibrosis. And then you have towards the end fibrosis as a result of NASH leading on to cirrhosis and maybe terminating into liver cancer also. The various risk factors for hepatic steatosis are: it is excess of body fat, whether it is generalized adiposity, subcutaneous or intra-abdominal adiposity, leading on to increased insulin resistance and metabolic syndrome. Again, age and gender, it usually tends to happen early in men by almost 50 years, in women by almost 60 years. When we talk about in terms of ethnicity, Asian Indians are at a greater risk as compared to blacks and Hispanics. And when we talk about diet and vitamins use, fructose, high carbohydrate intake, especially increased intake of saturated fats and trans fatty acid leads on to higher insulin resistance and hepatic steatosis. Physical inactivity classically predisposes to hepatic steatosis. And then there is unfortunately clustering, which has been seen in Asian patients. So there could be a genetic predisposition by virtue of PNPLA3 or maybe PPAR, RG or SREBC, which could predispose to higher prevalence of maybe cirrhosis, NASH, or Nephil or hepatic steatosis. As I said, Asian Indians are at a greater risk. So Asian Indians with Nephil, they have a high truncal subcutaneous fat as compared to any other race. If you see, and even non-obese, this is a paper from Dr. Anup Mishra, non-obese with BMI less than 25, those who are diabetic, they are also even at a greater risk for not only higher abdominal, but liver fat. So you see those patients who are diabetic, even if their BMI is less than 25 as compared to non-diabetic controls, not only they have higher total abdominal fat, they have higher intra-abdominal fat, maybe for same BMI, and their liver span is larger as compared to non-diabetic controls. So if I say that nearly 50% of non-obese patients with type 2 diabetes, they have Nephil, and this is what we also proved in our paper, which we presented at ACE 2019, where we said that even lean thin diabetics, they are at a greater risk of developing Nephil. It was almost 58% those who had BMI less than 25. By virtue of picking them up by RFI, we could pick up Nephil much earlier, and we said that novel metabolic score based on pentad of clinical, biochemical, and radiological profile of non-obese type 2 diabetes with Nephil, and it was seen in almost 58% contributing towards Nephil. So if you talk about overall prevalence data from India, I'll not go into the details of all studies as early as 2000 to 2007 and 9, almost 30 to 35% of patients, whether they are diabetic or obese, if you do an ultrasound, they will have an evidence of Nephil by one or the other criteria. So let's see what is the relationship of Nephil with diabetes and hepatic stenosis and what are the contributing mechanism. When you talk about metabolism of triglyceride in liver, there are three major sources. One is diet, which almost contributes to almost 15% of overall fat into the liver. When you talk of an endogenous synthesis, unfortunately, it accounts for almost 25 to 26% contributing towards steatohepatitis, and adipose tissue again contributing almost 60% because of insulin resistance into the adipose tissue and muscle. So you have increased production of free fatty acid contributing towards increased free fatty acids into the liver. Triglyceride production is on the higher side, and then it leads on to steatohepatitis. So it is not only the diet but the heredity predisposition, but also subcutaneous and visceral fat because of insulin resistance, which contributes towards pathogenesis of steatohepatitis. This is how the cycle goes on. Moment there is an increased insulin resistance into adipose tissue, I told you there is going to be an increased lipolysis, increased free fatty acid production. Adipokines, cytokines are on the higher side. Unfortunately, adiponectin goes on the lower side, and that leads to development of steatosis by getting increased triglyceride synthesis into the liver, which is not only lipotoxic, then these triglyceride derived metabolites, they lead on to mitochondrial dysfunction, ER stress, and then leads on to activation of inflammatory pathways or Kupffer cells hyperplasia, which then leads on to active steatohepatitis, and towards then leads on to steatohepatitis with fibrosis, finally leading on to cirrhosis and a greater risk of developing HCC or other sorts of liver cancer. So starting from steatosis, if you look on the spectrum of Nephil, there is going to be a NASH and subsequently a fibrosis, which then terminates into cirrhosis and high risk of developing HCC. Nephil and insulin resistance are more severe, as I said, in South Asian patients than other races. And again, this is a wonderful publication in 2006, JCI, which talked about liver triglyceride and insulin resistance in Asian versus white Caucasian in USA. Not only we tend to have much higher liver fat, our adiponectin levels are much lower, maybe even at a same amount of BMI as compared to Caucasian. So we tend to have much higher visceral fat contributing towards insulin resistance and contributing towards adiponectin reduction, which predisposes not only to NAFLD but stage liver disease also. So NAFLD could be associated with dyslipidemia, subclinical inflammation as well as CAD. So if you have look on the overall causative factors toward NAFLD and NASH with increased free fatty acids and cytokines because of dysfunctional adipose tissue, because of resistance into the adipose tissue, which will then lead on to dyslipidemia, which is classically seen in setting of type 2 diabetes with high triglyceride production, reduced HDL, and increase in ApoB and small dense LDL cholesterols. Not only this will induce hyperinsulinemia, but will also lead on to subclinical inflammation, atherosclerosis, and higher cardiovascular risk in these patients. So NAFLD independently actually predicts subclinical atherosclerosis in Asian patients as compared to Caucasian. For any level of presence of NAFLD or NASH, you tend to have much higher atherosclerosis. So may I suggest that there is a common link between NAFLD, metabolic syndrome, and type 2 diabetes, and it could be actually the existence of insulin resistance, not only into adipose tissue, but also into the liver, and that increased abdominal fat, which is primarily visceral fat, contributing or worsening insulin resistance. So NAFLD could be a hepatic manifestation of metabolic syndrome, or it could also be a precursor of metabolic syndrome. So it is a dynamic bidirectional relationship between type 2 diabetes and NAFLD. I'll not be going into the details of this algorithm, but suffice to say that moment you have increase in insulin resistance into the adipose tissue, into the visceral fat, into the liver, there is not only going to be an increased lipolysis, increased triglyceride production, which will lead on to characteristic dyslipidemia and predisposition to NAFLD, and the presence of NAFLD with worsening of insulin resistance then leads on to NASH, and then leads on to actually further built up in insulin resistance, then worsening hyperglycemia in the setting of type 2 diabetes. So when we talk of diabetes and NAFLD together, we know NAFLD is much more common in type 2 diabetics. Almost 50 to 75% diabetics, they have fatty liver by ultrasound. I told you our own study most of our patients were having BMI less than 25. Mean BMI was actually close to 24, and still we had almost 58% patient having established Nephil when we picked it up by RP. So the risk of NASH is 2.6 times in presence of hyperglycemia. So there could be elevated enzymes which could predict the future development of diabetes, and difficulty in obtaining adequate glycemic control in presence of NAFLD could be because of increased insulin resistance. So NAFLD and risk of type 2 diabetes is a very common link. Almost 11,000 patients in this Korean study which were evaluated after 5 years, their fasting insulin level at baseline and at follow-up, and it was seen those patients who had fatty liver, they were having much higher fasting insulin levels. In other words, they had much higher insulin resistance as compared to the control group. So the risk of developing type 2 diabetes at 5-year follow-up with overall incidence almost as high as in those patients who are having fatty liver, which is much higher as compared to someone who does not have a fatty liver at all. So if you study all the groups 1, 2, 3, and 4, irrespective of the education, smoking, exercise, obesity, or exercise level, alone liver fat predicted onset of type 2 diabetes in these patients, and fatty liver, that is why it is said that predicts future development of type 2 diabetes independent of insulin resistance and a baseline fasting glucose level. So Korean studies talk about, I told you that 107 patients with sustained fatty liver, they were followed for a 5-year period, and they were at a much greater risk for developing type 2 diabetes as compared to someone who didn't have NAFLD at all. So combined together, NAFLD, insulin resistance, and obesity could be a precursor of maybe type 2 diabetes developing almost 5 years. And this has been again proven in another study by Sung et al. In 2012, almost a follow-up data of 12,000 patients, those who were non-diabetic, and they were followed for a 5-year duration for incident diabetes. If they had NAFLD, insulin resistance, and obesity together, they were at a much greater risk. So this could be an independent predictor of onset of type 2 diabetes. Let me suggest you an algorithm for diagnosis of NAFLD NASH in patient with pre-diabetes or diabetes. All those patients who have pre-diabetes or diabetes, if their enzymes are normal, you can just leave them alone, and they could be just evaluated periodically like a standard care. Moment you have enzymes on the higher side, ALT, or maybe an ultrasound which is abnormal, rule out other causes of liver diseases, especially if you have a long-standing diabetes more than 10 years, if you have evidence of steatosis, maybe clinically or on ultrasound, if their HbA1c is more than 8.5%, their triglycerides are more than 250 milligram, and they have a genetic predisposition, we must assess these patients either by RP or by a fibroscan for the presence of fibrosis, or maybe an MR elastography to look for presence of fibrosis. If there is a low risk of fibrosis, again, these can be sort of followed up as a standard care. If you have an intermediate risk, ideally they should be undergoing a liver biopsy to prove the diagnosis of NASH if it is there, or if it is absent. All those patients who are at a greater risk or very high risk of fibrosis, not only lifestyle modification, they must be subjected to a definite treatment also. So let's see what is the algorithm for management of these patients, those who have definite NASH once it is diagnosed. So patient with pre-diabetes or type 2 diabetes with a definite NASH, not only control of other CV risk factors is going to be important, it is glucose control with metformin as a first line therapy, and ideal blood pressure control with ACE or ARBs as first line therapy, and lipid lowering, especially with statin as first line therapy. And you could add fibrates also if their triglyceride levels are very, very high. But if these patients have evidence of NASH, which is proven on RP or maybe MRI elastography or through a fibroscan, or maybe through a biopsy, these patients not only should be given a lifestyle intervention, a goal of at least 8 to 10% weight reduction, but they should also be subjected to pharmacological treatment in the form of pioglitazone as first line therapy, and second line could be different options. So potential therapeutic approaches to management of NAFLD could be with pros and cons. Weight reduction will go a long way, not only in improving all comorbidity, but also has long-term issues are that it may not be sustainable weight reduction. Diet, of course, it will improve all comorbidities. Again, there is a question mark whether it will have a long-term success level. Most of the patient, in terms of diet, exercise, as well as weight reduction, they fail to maintain their levels and targets. Antioxidant like vitamin E, I'll be discussing their trial, improves oxidative stress and inflammation, but long-term results are not there. Sensitizers like pioglitazone improves insulin resistance and blood glucose. Again, there could be some adverse effect because of long-term usage of pioglitazone, especially with 30 milligram. Statins, well, lipids along with fibrates could be of some use, of course, under the guidance of physician. Yeah, well, UDCA, it may decrease transaminases, but long term, there is no improvement in histopathology. Drugs like GLP-1 analog and SGLT2 these days are very promising in terms of reduction of NASH as long as there is no end-stage fibrosis. Well, I must discuss here a previous study which compared pioglitazone vitamin E versus placebo. It was 96 weeks trial where adults with NASH without diabetes, cirrhosis, hepatic heart failure or hepatitis C, those who had limited alcohol intake over last 5 years, they were enrolled and they were randomized either to pioglitazone 30 milligram 80 patient, vitamin E 800 milligram 84 patient, and placebo arm had 83 patient. And results were that there was a definite improvement in enzymes versus placebo with pioglitazone as well as with vitamin E. But insulin resistance reduction was primarily seen with pioglitazone. It was not actually seen with placebo or with vitamin E. But unfortunately, obviously, there was a weight gain because the study was with 30 milligram pioglitazone. These days, we advocate that we should give only 15 milligram of pioglitazone, which has all the benefits minus side effects. So weight gain happened in this study with pioglitazone over 96 weeks, although there was a reduction in insulin resistance and reduction in enzymes. Metformin, well, all 11 RCTs on 671 participants, where 27% patients were diabetic, has failed to show any improvement in terms of liver histopathology, although it improves glycemic control. We know it's a wonderful drug. TZs, of course, the mechanism of benefits in Nephil are different. It enhances fatty acid uptake and synthesis in adipose tissue, leads on to adipocyte differentiation. Adipocyte sort of evolve, and there is a formation of new adipocytes which are much more insulin sensitive as compared to the old stubborn adipocytes. It upregulates production of adiponectin, which is very, very significant. Reduction in peroxisome proliferative activated receptor nuclear expression has been demonstrated with pioglitazone. Vitamin E, again, it protects again oxidative damage and mitochondrial toxicity. So it could be of benefit in Nephil, what was seen in previous trial. But histological improvement and resolution of NASH has been seen both with vitamin E as well as pioglitazone in terms of improvement in Nephil activity score. Overall mean change has happened. But if you truly see, the fibrosis score does not change much. Liver enzymes improve. Overall, there could be some improvement in histopathology in terms of reduction in steatohepatitis, but fibrosis does not change. So long term, whether these drugs will reduce the progression towards NASH and end stage hepatic failure or cirrhosis is difficult to say because these trials are not very long. Prevalence was only for 96 weeks. So to summarize, consider screening for type 2 diabetes in every patient and look for other cardiovascular risk factors in these patients. Do active lifestyle intervention with a target of weight loss almost 10% by exercise and diet and lifestyle modification. Treatment of dyslipidemia has to be there with statin or maybe with fibrates, of course, with close monitoring of liver function enzymes. Treatment of type 2 diabetes, we must achieve good glycemic control with metformin. Consider early use of pioglitazone in diabetic patient with Nephil. Consider GLP-1 analog or these days SGLT2. I'm not going into the details of those trials, but there are very promising trials with SGLT2 inhibitor that there could be a reduction in Nephil score and overall activity, and it could actually check the progression towards NASH or fibrosis. Bariatric surgery also had limited success, and treatment of non-alcoholic steatohepatitis with selective drugs is going to be important. So to conclude, abdominal obesity and insulin resistance are linked between metabolic syndrome, type 2 diabetes, and Nephil. Actually, if we say it is a precursor of metabolic syndrome rather than the hepatic manifestation of metabolic syndrome. So Nephil should be looked upon as a precursor of not only type 2 diabetes and metabolic syndrome because Nephil increases the risk of incident type 2 diabetes. I've shown you 3-4 trials. Nephil is much more prevalent, unfortunately, in Asian patients. It tends to happen at a much lower BMI, less than 25. with much higher visceral fat and insulin resistance in these patients, contributing towards development of Nephil. Nephil is central to development of diabetes. Lifestyle management, including diet and exercise, will go a long way. And use of drugs like metformin, maybe vitamin E, high dosage 800 milligram, because there could be actually an increased risk of hemorrhagic stroke and CV death with vitamin E in the long term. So pioglitazone may be a better drug after metformin, or even maybe in the future, once you get an approval of SGLT2 inhibitors after metformin in the management of NAFLD, that could be a wonderful option. So we need to judiciously choose our options in these patients. Thank you very much for your patience listening. I'll stop sharing here and will be keen to have some discussion.